Sorry for the interference. So today we have two eminent speakers, and we have Dr. Amrish, who is going to introduce a moderator of the day, Dr. Gaurav Kapoor. Over to Dr. Amrish to introduce Dr. Gaurav. I'm sorry.
No, thank you so much, Dr. Kalavani. Can you please make it full screen?
Yeah.
And change the slide, please? Thank you. Yeah, so it's a pleasure and honor to introduce my colleague, Dr. Gaurav Kapoor today. Dr. Gaurav Kapoor is the Division Chief of Pediatric Nephrology here at Children's Hospital of Michigan. He is also the Director of Pediatric Dialysis Program, and he's the Professor of Pediatrics at Central Michigan University. Dr. Gaurav Kapoor initially trained in India at Maulana Azad Medical College. That's where he did his MBBS. And then subsequently, he did MD Pediatrics in Kalavati Saran Hospital. And then he started his fellowship at Children's Hospital of Michigan, and he has been here at Children's Hospital of Michigan for about 20 years. His special interests are pediatric dialysis. He has published in atypical hemolytic uremic syndrome. He has taken care of some very challenging cases of atypical HUS here, and he's the expert for HUS for us. He has very special interest in hypertension, and with Gaurav's permission, I can share that he has made a special sensor which can help in non-invasive monitoring. It is still in works, and I think you will definitely hear more and more about it. So definitely keep a watch out for that in the literature. He has, been an excellent teacher. He has been a mentor for a lot of nephrology fellows and pediatric residents. He has been honored as the top doctor here for the last 5 years. He also represents at the editorial board of pediatric nephrology here in American Academy of Pediatrics. And he was also the editor of the board in Frontier in Pediatrics. It has been a pleasure. Welcome, Gaurav, and I'll hand over the session to you.
Thank you, Amrish, for that excellent introduction. Appreciate it. I have the honor of introducing today's first speaker, Dr. Anil Vasudevan. Dr. Vasudevan is the professor and head Department of Pediatric Nephrology at St. John's Medical College Hospital. He is also the adjunct professor in the Division of Molecular Medicine at St. John's Research Institute, Bengaluru. He, along with his appointments at St. John's, he is also the secretary of the Indian Society of Pediatric Nephrology and is a member of Committee of Competence-Based Syllabus in Pediatric Nephrology and the PhD committee at JIPMER and St. John's National Academy of Health Sciences. He also serves on the editorial board of Asian Journal of Pediatric Nephrology and is the webmaster for Asian Society of Pediatric Nephrology. His areas of special interest include genetics of renal disease, molecular basis of nephrotic syndrome, acute kidney injury, and low-cost devices to their application in pediatric nephrology. So without much delay, I'll have Dr. Vasudevan start off today's session with his very interesting talk. Welcome, Dr. Vasudevan.
Thank you. So as I share my screen, I'd like to thank Namal Vasa, the mentor for this webinar of the past and the present webinar series, the course directors of this webinar series, Dr. Kalavani, my good friend, Dr. Amrish Jain, and I also thank Dr. Gaurav Kapoor for the generous introduction. So I'm going to speak on the genetic approach to developmental abnormalities of kidney and the urinary tract, which is a commonly occurring birth defect and probably one of the most common causes of end-stage kidney disease in children. And as we all know, nephrogenic is a rapidly advancing multidisciplinary field that is focused on deciphering the causes and manifestations of kidney disease with an underlying genetic etiology, and hoping that genetic testing will help not only the diagnosis but also management of these children. So quickly over the next 25-30 minutes, I will be very briefly reviewing initially the definition, the epidemiology, and the basic concepts of kidney development. And thereafter, I go into the genetic basis of CAKUT and an approach. I mean, there are no guidelines or anything, but what we commonly do when we see a child with CAKUT. And of course, with any form of testing or investigation have its own challenges and barriers, which I will be briefly discussing about. So CAKUT refers to is an umbrella term encompassing a large number of malformations, which are an outcome of abnormal embryonic development of the kidney and urinary tract. And these are often associated with various clinical manifestations and functional consequences. As you can see from this, from the second line, that it's not an uncommon etiology. In fact, the prevalence ranges anywhere between 3 to 6 per 100,000 births. A rare disease is something which is a prevalence of 1 in 100,000 population. And not only that, this condition is associated with significant morbidity, as more than 1/3 of them have progressed to end-stage kidney disease. And if you take a cohort of end-stage kidney disease, probably 2/3 of them are CAKUT. And this can appear either as a sporadic or an isolated manifestation or as part of some specific syndromes. So what are these CAKUT? It's like I said, it's an umbrella term. So there are various etiologies or function or structural anomalies that come under this. And it is a very controversial term which is introduced probably a decade back. And it can affect any part of the kidney and urinary tract. It could involve the kidney parenchyma, such as in hypodysplasia, renal agenesis. It could involve the draining tract, that is the ureters, such as in psychoureteric reflux, duplication of the pelvic calyceal system. It could involve the urethra, such as in posterior urethral valves, or in the uretropelvic junction obstruction. Apart from structural anomalies that is seen here, it can also cause abnormalities in the numbers, such as unilateral renal agenesis, or in the site, such as in ectopic kidney or horseshoe kidney. Now, a very controversial inclusion in this is the neurogenic bladder, because most of the neurogenic bladders are secondary and they are not primary developmental anomalies, probably secondary to the spinal defects, leading to wherein the abnormal innervation leads to this neurogenic bladder, or could be a consequence of an obstructive uropathy, as you see in posterior urethral valve, or could be a part of the bowel bladder dysfunction. So, and apart from that, there are other anomalies that are also considered in CAKUT, such as ureteroceles and megaureters. Now, unique part of CAKUT is that these anomalies could be unilateral or bilateral, and there could be different manifestations on either side, which I'll come to a bit later. Now, when we see a child with CAKUT, we should also look and think beyond the kidneys, because probably 15 to 30% of these children with CAKUT can have extra kidney manifestations. To date, more than 200 clinical syndromes are identified that have very features of CAKUT as part of the distinct phenotype. A challenge in a clinical setting is of two kinds. One, wherein we may not be able to identify the extra kidney features unless we look for it, because these are often subtle or silent or non-specific. Conversely, in these syndromic children, the CAKUT may not be diagnosed because they have no clinical symptoms, or may be diagnosed as an incidental finding. And these extra kidney manifestations can commonly involve the CNS, the ears, the eyes, such as you see in renal coloboma syndrome, the cardiac diseases, and also skeletal involvement. So before we go to the genetic basis of CAKUT, a very quick review of the basics of normal development of the kidney and urinary tract. I think this must have been covered in the first session. Broadly, there can be 4 stages. One is of the ureteric bud inducement. Second is the mesenchymal to epithelial transition in the metanephric mesenchyme. Then there is branching, followed by patterning, final patterning, and the elongation of the nephrons. And along with this is the simultaneous development of the bladder and the urethra. So a critical event in the kidney morphogenesis is the invasion of the ureteric bud into the metanephric mesenchyme and the branching, which is not only important for the radial arrangement of the nephrons, but also determines the number of nephrons each kidney has. And this starts in the early gestation and continues up until the child is born, or up to between 36 and 40 weeks. So the kind of anomaly is also may happen based on the timing of insult during the gestational period. So in the early gestational period, insults can lead to parenchymal defects such as kidney agenesis or hypodysplasia, which may continue throughout the gestation because the branching and the development of the nephrons continues throughout the period of gestation, whereas perturbations in the later gestation underlie the outflow tract abnormalities such as posterior urethral valve and uretropelvic junction obstructions. Now, this complex process of the kidney development is regulated by a host of transcription factors and proteins that are encoded by various genes. And you could almost consider this like a large orchestra where there are a number of instruments that are played by a number of players which are grouped. And in each group, you can have the lead player with a supporting players. And these musical instruments come in and out, wax and wane during the symphony. And these are all conducted by a master conductor, which may be one or more than one. So something similar here happens in the kidney development, where these host of regulators regulate different components of the kidney development, from the ureteric blood branching to the invasion of the metanephric mesenchyme, the patterning of the nephrons, the development of the ureter and bladder, and so forth. And these molecules may play a role in different stages of kidney development. It may be in the initial stages, or it may be in the final maturation stages of the development, such as in an example here shown in the development of the nephron, which progresses through various stages like aggregation, coma shape, S shape, the vesicle, and the final mature nephron. There are many regulators that you can see here are shown to regulate these different stages of development. And why this is important to know is that the kind of anomaly will depend upon the spatio-temporal interactions of these molecules within these different regions of the kidney. Either it is the ureteric bud, metanephric mesenchyme, or the ureter. While there is enough evidence to suggest that CAKUT is of monogenic origin, such as family history of CAKUT, you have elegant mouse models wherein monogenic causes of CAKUT has been demonstrated. The fact that it is congenital in nature and specific syndromes have been identified with the monogenic etiology. But there are other aspects which are unique, which suggest that it is probably something beyond the Mendelian inheritance pattern, such as the anomaly being present only on one side, that is unilateral versus bilateral, being present as an isolated CAKUT versus a syndromic CAKUT. And in addition, the high phenotypic variability not only seen between cases within families, but even within the two kidneys and the urinary tract of the same patient exhibiting different anomalies. For example, you could have a multicystic dysplastic kidney on one side. On the other side, you can have a reflux or a uretropelvic junction obstruction. So all this suggests that there may be other pathways that could be involved, or there may be other pathogenic factors such as epigenetics or even environmental factors. So what I forgot to say that during the development of the kidney and the urinary tract is that there are a lot of hormonal and metabolic influences that regulate the development, apart from the transcription factors and other proteins. For example, mothers with diabetes are at high risk of having children with CAKUT, suggesting that metabolic environment may modify the expression of diseases. But my talk is primarily focused on the monogenic causes of CAKUT. And with this background, we will now go into the genetic basis of CAKUT. And before that, I would like to introduce some basic concepts. So as we all know, the goal of genetic testing is to identify variants that causes the disease. And these genetic variants can be binned into 3 broad groups. The most common are what is called the single nucleotide variants, or small insertions, deletions, and substitutions that involve probably 1 base pair up to 100 base pairs. The second most common form of variants that are identified with genetic testing are the copy number variants, that are large insertions or duplications that encompasses more than 1,000 base pairs, that is 1 kilobase, to up to 100,000 base pairs, that is in megabases. And lastly, usually seen in syndromic forms are the large chromosomal aberrations such as translocations, deletions, duplications, and so on. And in genetic testing, we try to most commonly identify the small single nucleotide variants or small insertions or deletions using sequencing approach. And most of these variants that causes disease are located in the exonic region. So why is this important to know? Because the kind of genetic testing that you'd like to order is based on the probability of which of these variants are likely to cause the disease. So if in a syndromic child, if you're suspecting a chromosomal aberration, then we need to do a karyotyping. Suppose we are suspecting a copy number variations, that is large insertions or duplications encompassing a large number of bases, then we need to order the microarray, or what is called a multiplex ligation dependent probe amplification. And if you're looking at single nucleotide variants or small insertion deletions, you order what is called the sequencing, and which could be a Sanger sequencing, or more recently, what has become very popular and very effective is the massively parallel sequencing technologies, or what is formerly called the next generation sequencing. And in this, we have different types of approaches that includes clinical exome analysis, targeted panel, and whole exome analysis. Generally, the whole genome analysis is not used in a clinical setting. So one of the first studies that looked at genetic causes of CAKUT was the ESCAPE study, which is primarily looking at use of AC inhibitors in control of hypertension and proteinuria. In this secondary objective, they looked at 100 children wherein they sequenced using Sanger sequencing 5 genes. And a point to note is that 1/3 of these children had extra kidney anomalies involving various organs of the body, such as cardiac, hearing, diabetes, eye, and so on. And when they screened for these 5 genes, they identified variants that was deleterious in 17 of them. And most commonly, the gene identified were hepatocyte nuclear factor 1 beta and PAX2. Subsequently, many studies have looked at either a gene or a group of a gene in various cohorts. Mostly in the cohort included children with renal hypoplasia and very few with outflow tract anomalies such as VUR or EPGO. And what you find here is that the most common gene that is found to be positive for CAKUT is HNF1 beta and PAX2. As you can see here, maybe 20% and 10% of those in whom they screen in their cohort were because of the variants in these 2 genes. Whereas in other genes, it is probably 1 to 3%. And this finding was replicated in the CAKUT cohort, where they again found that 10% of their children with CAKUT had variants in one of these genes. Most commonly is the HNF1 beta and PAX2. And in addition, various studies that looked at genetic testing in fetus using either chorionic villus sampling or amniotic fluid analysis also found a similar finding of hepatocyte nuclear factor 1 beta and PAX2 as the most common genetic etiology for CAKUT. In fact, the Belgium group, Levenschko and her team has devised a criteria to predict whether the CAKUT could be because of HNF1 beta. So they have something called the major criteria and the minor criteria, along with extra kidney features of hypomagnesemia and diabetes mellitus. So the probability of having HNF1 beta mutation is very likely if there are either of the 2 major criteria. That is, either they have a hypodysplasia or a multicystic dysplastic kidney or a renal hypoplasia. And this odds increases if there is hyperuricemia or of renal cyst of unknown origin. So it seems like when you use a candidate gene approach, only around 10% of them have identified genetic etiology, and most commonly affecting HNF1 beta and PAX2. The odyssey of identifying genetic etiology in kidney disease accelerated with the use of MPS-based genetic testing technology, and it also included CAKUT. And this was one of the first earliest studies that used a exome sequencing approach. And this is an international multi-center study from the Hillenbrand's group, wherein, again, with this approach, they showed that around 14 to 17% of the family have an identified genetic etiology. And as you can see here, those with history of consanguinity, or those with syndromic manifestations or severe CAKUT phenotype, basically involving the renal parenchyma, the genetic etiology was much higher, that highlighted in blue. So it seems like there are specific groups within CAKUT that are more likely to have a genetic etiology. And this is one of the most recent studies. This is a single country multi-center study from China that again looked at the genetic etiology using an exome sequencing-based approach in their cohort of CAKUT. They divided the CAKUT into 7 groups. The top half consists of the single kidney, hypodysplasia, unilateral or bilateral, then PUV, MCDK, and horseshoe kidney. Then they've been the other conditions such as VUR, duplicating system, ectopic kidney, UPJO into a single group. And they found a similar hit rate as observed with Hillenbrand's study. They found that 10% of these CAKUT have an underlying genetic etiology. And similar to what they found, what Dr. Hillenbrand and group found, a family history, presence of extrarenal features, and bilateral renal hypodysplasia. These are the children in whom there can be a higher probability of having a genetic etiology, close up to 25%. And again, here, the most common etiology, genetic etiology identified was PAX2, HNF beta, GATA3, and SAL1. So these studies, whether you're using a candidate gene approach, using Sanger sequencing few genes, or an exome sequencing, really did not increase the yield of genetic testing, unlike that we saw in conditions such as nephrotic syndrome and tubular diseases. So the focus went to identification of other types of variants. And we also conducted a small study trying to identify the genetic etiology in our cohort of CAKUT, where we had a cohort of close to 125 patients. And in this, we identified 69 patients randomly. And what we did was a targeted panel of 31 genes that are commonly associated with CAKUT. As you can see, our cohort mostly consisted of those of reversicular reflex, posterior urethral valve, and lesser children with isolated renal hypodysplasia. And our sequencing results did not yield any identified pathogenicity, while we identified a lot of variants of unknown significance. Close to 2/3 of those variants identified were VUS, and of which probably a quarter of them were potentially damaging. And all these variants were VUS because they were all novel. And this indicates that the genetic yield may differ based on the kind of population, that is, whether it involves the lower urinary tract or the kidney, and also the ethnicity of the cohort, and also the kind of testing. So while the genetic testing using exome sequencing or Sanger sequencing did not increase the yield of identifying the genetic etiology, the focus moved to identifying other types of variations. For example, the copy number variations, which I said are large insertions or deletions encompassing more than 100,000 base pairs. So this is a study that summarized the results from 3 large studies, wherein there are around 800 patients of CAKUT, and compared it with other studies that have looked at CNV. So as you can see here, there is a fair amount of enrichment of copy number variants in children with CAKUT, close to 10%. much higher than other diseases such as autism and cleft lip and so on, but lower than in other diseases such as cardiac disease and neurodevelopmental delay. Now, where are these copy number variations located? So when they analyzed the data, they identified close to 40 regions. And most of these regions have already been mapped to other disorders, mainly the cardiac and the neurodevelopmental defects. And they identified that both insertions, which are highlighted in, deletions, which are highlighted in red, and duplication, which are highlighted in green, have been associated with CAKUT. And of these 40 genomic loci, 4 loci were most commonly associated with CAKUT, and they accounted for more than 2/3 of the genetic etiology, mostly involving chromosome 1, chromosome 16, chromosome 17. Actually, in this region is the hepatocyte nuclear factor 1 beta located, and also 22q11, which is typically associated with DiGeorge syndrome. And as you can see here, in all these regions, the deletion was associated with CAKUT as compared to duplication, which is in blue. Now, the next question that came up was, does this type of CNV vary with the type of CAKUT? So this is a study that looked at this question. And as you can see here, these two figures, the left side shows copy number variations associated with known genomic disorders. That is mapped to other disorders such as cardiac and neurodevelopmental. And on the other, in the other figure, it refers to copy number variants that are novel, that has not been identified in other conditions. As you can see here, in both of them, the deletions, which is in yellow, is common as compared to duplication, which is seen in blue. But if you look at different types of CAKUT, it gives some interesting information. As you can see here, those associated with kidney parenchymal defects, such as renal hypodysplasia, you find more of deletions, both in the known and novel genomic loci. Whereas if you have a PUV or a duplicating collecting system, or that is involving the outflow, the lower urinary tract, you're more likely to find duplication in the as the cause of the CAKUT. So clearly there is a difference in the type of CNV that are associated with various subtypes of CAKUT, be it the parenchymal or the lower urinary tract. So in summary, what this data show is that probably a single gene effect can be identified in 10 to 15% of the patients of CAKUT, and copy number variations can account anywhere between 5 to 10% of the CAKUT. So overall, probably 1/4 of the children have an identified genetic etiology, whereas the rest 75%, we haven't been able to identify the genetic etiology. The data also shows that you're more likely to find a genetic etiology if there is a renal hypodysplasia as compared to vesicular reflex, and the least is in obstructive uropathy, such as in posterior urethral valve. The data that I have not shown is of an adult. What is shown also is that when you do this genetic testing in adults with CAKUT, the yield is similar. That is around 25% of 10 to 25% of them have an identified genetic etiology as similar that is observed in children. So these are the common genetic genes that have been identified with CAKUT. On the top are those genes, around 20 of them, that are associated with isolated CAKUT, whereas in the lower half, these are around 13 genes that are associated with syndromic form of CAKUT, and these are the most common genes that needs to be screened. What is of interest is to note is that most of them have an autosomal dominant pattern of inheritance, be it the isolated or in the syndromic form, and this could be a challenge while interpreting the genetic test results. Although there are 174 of these causes, I've listed only the top 40 of them, because in the rest, the CAKUT is usually seen in less than 50%, especially in the syndromic forms. Apart from these monogenic forms, copy number variants, as I have already mentioned, in these 4 loci account for 2/3 of the patients with CAKUT. So another challenge when you come to genetic testing is pleiotropy. So what is pleiotropy? Pleiotropy is nothing but where the manifestations in different patients are so different. It seems like they are of different pathogenesis or different etiology. For example, variations in the gene EYA1 can cause syndromic CAKUT, such as in bronchiotorhinal syndrome, or it can cause isolated defects, such as uretropelvic junction obstruction or uretrovesical junction obstruction. So it seems like, there are different phenotypes suggesting different pathogenesis, but it is actually a consequence of variations in the same gene. And this is known as pleiotropy. So let's now take a case of an 8-year-old child who came to us, presented with failure to thrive, noticed since 1 year, also had some developmental delay and poor scholastic performance. On examination, had some spinal anomalies, and X-ray did show some cervical spinal anomaly, and show whether it's clear. And ultrasound revealed small kidneys, and when we did an MCU, the bladder was normal and with evidence of reflux on one side. Now, the question is, should we do a genetic testing to identify the etiology? So genetic testing is a multi-step process and a multidisciplinary activity. And there are a lot of components in this, but very briefly, it boils down to whom to test, what kind of a genetic testing should be used, and how will this genetic testing be useful to the child and the family. So whom do we test in a child with CAKUT? So as the data shows, younger the onset and more severe the CAKUT, the more severe the hypodysplasia, family history or history of consanguinity. If there are cystic or parenchymal abnormalities in the kidney, it's more likely to have a genetic etiology. Another group where they have looked at, try to understand the genetic etiology, are those children and adults who presents with end-stage kidney disease with unclear etiology. Even in them, they have found that close to 10% can have CAKUT of a genetic origin. So once we decide on whom to test, the second is what kind of a genetic testing method should we use? Now, this is a summary of studies that have shown the diagnostic yield using sequencing method in various conditions and using the diagnostic used based on only on identifying copy number variants. And as you can see, as compared to other kidney diseases, in CAKUT, the yield is pretty limited when you use sequencing, while when we're using copy number variations, it seems to be one of the kidney diseases that have a high proportion of etiology of copy number variations. So of these two tests, that is sequencing versus identifying copy number variations, what test do we order? So if you're looking at parenchymal abnormalities or specific syndromes, such as syndromes wherein there is urogenital involvement, skeletal involvement, cardiac involvement, then you go for clinical or whole exome sequencing. And if you have an extra kidney involvement specifically involving the neurodevelopmental, deafness, or cardiac defects, you could consider array-based genetic testing method, either comparative genomic hybridization or a SNP array. So in general, if you do not get a result using either of them, suppose you go for an exome sequencing, you don't get an identified genetic etiology, you could go for an array. Vice versa, if you have used array as your first genetic testing method and you don't get a result, you could go later on for whole exome sequencing. This is just a rough guideline to how to choose a genetic test. Now, how is it useful for the patients with CAKUT? While it not only helps in establishing a diagnosis, especially in children who present with end-stage kidney disease, where we are not sure whether it was a CAKUT or not, it also helps in identifying and providing better care for children with extrarenal anomalies. And I will just come to this from how useful it is it was found in a study. And also what has been found that many of them may have neurodevelopmental anomalies, and probably identifying them may help in introducing interventions that can improve outcomes, not just for the kidney. It's mainly a supportive care, but involvement of the brain, you could have a potential to introduce interventions that can improve their outcomes. So this is one study that highlighted the importance of genetic testing in CAKUT. This is again a study from Hillenbrand's group, wherein they used exome sequencing of 174 genes in more than 700 families, and they identified a genetic etiology in 11%. What is interesting is the further sub-analysis. So as you can see here, they have categorized them into 3 groups. The first group consisted of individuals that were screened for 23 genes that are known to cause isolated CAKUT, and the yield was around 38%. The second group consisted of children who had an etiology identified in 16 of the known syndromic genes, while in the third group there were children who had variants in 135 genes that were identified with syndromes not commonly associated with CAKUT, where 50%, less than 50% of them have CAKUT. So as you can see here, of the children in whom a syndromic gene was identified, actually they were diagnosed as isolated CAKUT. Upon identifying the genetic etiology, they screened for extrarenal symptoms and they reclassified them as syndromic CAKUT. Similarly, in 3 of those patients with a syndromic gene, they were initially diagnosed as isolated CAKUT, but upon obtaining the result of the genetic testing, they identified extra kidney features that helped them reclassify this as syndromic CAKUT. So not only it helps in changing your diagnosis from isolated to syndromic, it also helps in identifying those extra kidney features that may require more monitoring and further management. So this is one of the key utility of genetic testing in CAKUT. While the utility is there in diagnosis and identifying the extra kidney features, there are a lot of challenges. In fact, more than 75% of them, when you test, do not have an identified genetic etiology. And the challenges remains with interpretation because most of them have an autosomal dominant form of inheritance. So these children have variable expressivity and incomplete penetrance, making a clinical diagnosis difficult. And also interpretation of the variant identified becomes difficult, especially in the Indian setting, because most of them are novel and we don't have the allele frequency in a general healthy population. Beside that, exome sequencing has identified variant in other genes also, along with even in copy number variants. So this brings into the concept whether they are really monogenic or not, and whether there are variants that can modify the expression of this disease, so-called oligogenic inheritance. Or it could also be that many of these CAKUT have a polygenic model because and also multifactorial, because the fetal environment also may impact on the disease expression. So these are the challenges with the current available way of genetic testing. So in summary, there are over 50 genes and 40 genomic disorders that have been identified with both syndromic and non-syndromic forms of CAKUT. Chromosomal microarray, whether it's a CGH or a SNP array, should be strongly considered as a first-line diagnostic approach for CAKUT cases, followed by sequencing method in those with neurodevelopmental issues. But we should remember that the clinical heterogeneity of the CAKUT subphenotype poses a significant challenge in human genetic studies aimed at identifying the genes underlying these conditions. And hence, this requires a multidisciplinary international collaborative approaches that intersects genetics, genomics, in vitro and in vivo modeling with deeply phenotype cohort of CAKUT in order to develop a very accurate genetic testing strategies. Thank you for your patience.
Thank you, Dr. Vasudevan, for an excellent presentation. And thank you for making a very challenging topic very interesting. I would once again like to remind all the participants to please post your questions in the Q&A section, and we will take all the questions after the second lecture by Dr. Uma Maheshwari. So can we move on to the next slide, please?
Dr. Vasudevan, if you could stop sharing your slide, and we'll have Dr. Kalam. Thank you so much.
Thank you. So our next speaker is Dr. Uma Maheshwari. She is she's at Mehta Hospital, and she's a pediatric nephrologist there. And her topics of interest include nephrotic syndrome and acute kidney injury, and she is published in international journals. I welcome Dr. Maheshwari for her talk on MCDK, multicystic dysplastic kidney.
Thank you, sir. Thank you for your kind introduction. Very good evening to one and all. I'm really glad to present a topic in front of so many eminent pediatric nephrologists. I'm going to give a talk on multicystic dysplastic kidney.
Ma, can you start sharing?
Yes, ma'am. Multicystic dysplastic kidney, an overview. Multicystic dysplastic kidney is one of the most common cause of cystic kidney disease in children, next only to antenatal hydronephrosis. It is characterized by multiple non-communicating cysts of varying sizes with no identifiable renal parenchyma with an atretic ureter. It is the second most commonly detected anomalies on prenatal ultrasound. Incidence reported is approximately 1 in 4,300 live births. This is the incidence of unilateral disease, whereas bilateral disease is seen in 1 in 8,000 to 10,000 live births. It most commonly affects the left side and has male predominance, 55%. In a study by Society of Fetal Urology, the antenatal detected renal anomalies were mostly hydronephrosis, among which multicystic dysplastic kidney was seen in 4 to 6% of cases. Etiopathogenesis. According to ureteric bud theory proposed by Mackey and Stephens, multicystic dysplastic kidney results from an abnormal interaction between the ureteric bud and the metanephric mesenchyme. There is another theory of renal pelvic ureteral atresia and obstruction, which lead to MCDK, has also been proposed. Other less accepted theories include teratogens, medications like anti-epileptic drugs, and viral infections like CMV, enterovirus, and adenovirus. It usually develops as a sporadic problem. Familial occurrence have also been reported. In familial cases, transmission is autosomal dominant with a recurrence risk of 50%. This shows that there is a ureteric bud and the metanephric blastema. The proper induction of the ureteric bud into the metanephric blastema develops into normal kidney, whereas the abnormal induction between the ureteric bud and the metanephric blastema results in this multicystic dysplastic kidney. Let's move on to genetics part of MCDK. Mutations in the HNF1 beta gene 17q12 coding for hepatocyte nuclear transcription factor 1 beta, it is associated with renal cyst and diabetes syndrome, have also been associated with unilateral MCDK. MCDK is also linked to gestational diabetes. EYA1 or 6-1 gene mutation or 6-5 gene mutation, which lead to bronchoautorenal syndrome, abnormal PAX2 gene expression that result in renal coloboma syndrome have also been implicated. Dominant mutations of CHT1L ROBO2 and SAL1 genes have also been found to be associated with MCDK. Hereditary multicystic dysplastic kidney has also been reported, which showed that it was found to run in 3 generations of a family. As Sir told early, the pathogenic copy number variations were detected in 13.5% of cases of MCDK. The karyotype analysis in a study revealed that 4.17% of fetuses with MCDK had chromosome abnormalities. However, chromosomal microarray analysis might increase the detection rate of submicroscopic imbalances to an additional of 16.7% of the cases. This chromosomal microarray analysis can replace karyotype analysis and be used as the first clinical diagnostic test for fetal MCDK. 4 new chromosomal regions have also been possibly associated with MCDK, which are 22q11 duplication, 22q13 duplication, 4q35 deletion, and 1p33 duplication, which have been identified recently. This shows that a substantial proportion of MCDKs were associated with pathogenic CNVs, which were 2 17q deletions, 1 untypical 22q11 deletion, 1 22q11 duplication, and 3 of the 5 pathogenic copy number variations were inherited. Family members were the same copy number variation, were asymptomatic, or they had different kind of renal malformation. So those who have been identified with multicystic dysplastic kidneys, instead of karyotype analysis, they show that it may be reasonable to perform chromosomal microarray analysis. These are the few syndromes which are associated with MCDK. Alagille syndrome with bile duct paucity, Beckwith-Whitman syndrome, branchio-otorenal syndrome, where they present with branchial cyst, sensorineural deafness, and multicystic dysplastic kidney, hypoparathyroidism, deafness renal syndrome, Joubert syndrome, maturity onset diabetes of the young, type 5, renal coloboma syndrome, trisomy 18, Bacterial association, Waardenburg syndrome, and Williams syndrome. These are the few malformations which are associated with multicystic dysplastic kidney. Gastrointestinal malformations include duodenal atresia, esophageal atresia, Hirschsprung disease, imperforate anus, inguinal hernia, omphalocele, and tracheoesophageal fistula. Neurologic malformations are anencephaly, caudal agenesis, hydrocephalus, mental retardation, microcephaly, myelomeningocele, and congenital deafness. Cardiovascular malformations which are associated include aortic stenosis, coarctation of aorta, patent ductus arteriosus, pulmonary stenosis, truncus arteriosus, and VSD. Musculoskeletal malformations which are associated include clinodactyly, congenital dislocation of hip, flexion deformities, syndactyly, and talipes equinovarus. The urinary tract abnormalities, which are most commonly associated with unilateral multicystic dysplastic kidney, include vesicoureteric reflex, which are found in 4 to 19% of the patients, uretropelvic junction obstruction seen in 7 to 12% of patients, posterior urethral valves, uretrocele, and horseshoe kidney. Up to 39% patients present with abnormalities in the contralateral kidney. This is a study where they showed the demographic details of subjects with multicystic dysplastic kidney, comprehensive analysis of 67 articles which were published. It shows that almost 35.9% had associated urinary tract abnormalities. 20.4% had vesicoureteric reflex. PJ obstruction was seen in 3.6% of cases. Uretrocele was seen in 1.3% of patients. Horseshoe kidney was seen in 0.43% of patients. Posterior urethral valve in 0.54% of patients. Let's move on to histology. Gross examination of a typical multicystic dysplastic kidney reveals multiple variable size cysts in a bunch of grapes type of cluster with very little intervening stroma, loss of reniform configuration, and an absence of a calyceal collecting system. The renal artery and vein are usually hypoplastic and sometimes absent. The ureter may be absent but is usually atretic. In case of unilateral renal agenesis, this atretic ureter may be the only clue to a regressed MCDK. This is the microscopic light microscopic finding. Microscopic examination reveals large cyst lined by flattened cuboidal epithelium and an intervening parenchyma that is fibrotic with islands of bluish cartilage and rare glomeruli. Other findings include metaplastic cartilage, loose fibrous tissue, and primitive tubules. Natural history of the disease. It is one of the most commonly detected renal anomalies on antenatal USG, next only to hydronephrosis. It can be detected as early as 15 weeks of gestation. This shows the multiple cysts in the antenatal ultrasound. The bilateral multicystic dysplastic kidney may present as stillbirth or death within few hours after birth due to pulmonary hypoplasia. Involution of the MCDK may start before birth itself in 5% of the patients. 54% of the dysplastic kidneys involute by 5 years of age and 62% of them involute by 7 years of age. Those more with kidneys more than or equal to 7 centimeter in length rarely involute. The contralateral kidney undergoes compensatory hypertrophy by mechanisms which have yet to be fully understood. The Spira et al. In a study showed that renal length of the hypertrophied kidney should be greater than the 50th centile for body length. This is the involution rate which was described by Hayes et al. In their study. It shows that the dysplastic kidney, if it is less than 3 centimeter, 90% of them involute. If the kidney size is between 3 to 4.9 centimeter, almost around 50 to 60% of them involute and undergoes complete involution. If the kidney size is between 5 to 6.9 centimeter, almost 20% of them undergo complete involution. And if the kidney size is more than or equal to 7 centimeter, they rarely involute. Clinical presentation. 60 to 80% cases of unilateral multicystic dysplastic kidney are detected antenatally. If they are not detected antenatally, mostly they are asymptomatic. They present in the newborn period as a palpable abdominal mass in 13 to 22% of cases, or urinary tract infection in 5% of the cases. Most often, grade 1 to 3 VUR can be seen associated with the unilateral MCDK in the contralateral kidney. Only 2 to 5% will have severe reflux resulting in recurrent urinary tract infection, which may progress to end-stage renal disease. Low-grade proteinuria can be seen in 5 to 30% of patients, and it is also associated with the prevalence of unilateral or bilateral undescended testis in 12.7% of patients. And let's not forget that there may be malformations of the ipsilateral internal genitalia in up to 15% of them in the form of seminal cyst and Gardner's duct in boys, even with involuted multicystic dysplastic kidney. Ovira syndrome, that is obstructed hemivagina with ipsilateral renal agenesis after spontaneous involution of MCDK with double uterus, was seen in 1.25% in a study. Hypertension is seen in 1 to 6% of population, which is almost less than the incidence in normal population, which may be due to the minimal residual functional parenchyma in the dysplastic kidney. There was a case report wherein an infant with multicystic dysplastic kidney presented with hypertension very early in the newborn period. They had started the infant on ACE inhibitors. The infant did not respond, so hence nephrectomy was done at 7 months of age, after which the hypertension came under control. The renal malignancy incidence in a patient with multicystic dysplastic kidney is very rare. The incidence is almost similar to the incidence in the normal population. In a study, they found that 1,600 nephrectomies have to be done if at all, while one Wilms tumor have to be prevented in a multicystic dysplastic kidney. Hence, prophylactic nephrectomy in a dysplastic kidney is not indicated. Evaluation. We begin our evaluation from antenatal imaging and prenatal counseling regarding the prognosis of the disease. And postnatally, we do ultrasound to confirm the finding in the antenatal from the antenatal ultrasound. The differential diagnosis when we see a multicystic dysplastic kidney in an antenatal ultrasound can be a PUJ obstruction or a congenital Wilms tumor or a polycystic kidney disease. We follow the renal ultrasound with the urine analysis, creatinine, urea, and electrolytes, and blood pressure monitoring. The renal ultrasound is done every 6 to 12 months until 5 years of age or until involution is noted. If there is dilated ureter visible in renal ultrasound, or if the DMSA, which is done at 3 months of age for confirmation and functioning of the contralateral kidney, shows scar in contralateral kidney, or in cases of recurrent urinary tract infection, micturating cystourethrogram is indicated. And DTPA renal scanning is done only if we suspect uretropelvic junction obstruction or vesicouretic junction obstruction in the contralateral kidney. This is a sonographic picture showing the multicystic dysplastic kidney, which are non-communicating with each other, whereas this picture shows bilateral severe hydronephrosis with the dilated renal pelvic alluvial system. Treatment, it's conservative management. Antibiotic prophylaxis is indicated in case of vesicouretic reflux in contralateral kidney. Indications of nephrectomy are refractory hypertension. If kidney is not involuting, presenting as a large abdominal mass, as if it is more than or equal to 7 centimeter, recurrent urinary tract infection, if it involves a dysplastic kidney with a minimal functioning parenchyma, or in case of malignancy, which is very rare. There was a study where they had followed up the patients with multicystic dysplastic kidney into adulthood, in which they noted that hypertension was seen in 27 to 47% of patients. Proteinuria was seen in 23 to 47% of cases. Renal insufficiency in 3 to 13% of patients. And this is a follow-up study which was done in Dr. Mehta's hospital by Dr. Vijay Kumar sir and his team. It was found, we followed up 31 patients, among which one patient had ureterocele and one patient had ectopic ureter. And it's during follow-up, we noted they noted that 7 patients had undergone complete regression and 14 patients had partial regression of the dysplastic kidney, and 4 patients, there was increase in size in 4 patients and there was no change in kidney size in 2 patients, and 4 patients had undergone nephrectomy. Contralateral compensatory hypertrophy was seen in all 31 patients. Renal failure was seen in 2 patients and there was subnephrotic proteinuria in 9 patients. Differential diagnosis. I would like to conclude my talk by giving an overview in the differential diagnosis for cyst in children. Unilateral or bilateral small echogenic kidneys with disorganized parenchyma suggest multicystic dysplastic kidney. If there is a unilateral small cyst in the kidney, simple renal cyst, it could be a simple renal cyst or it could be a early autosomal dominant polycystic kidney disease. There is bilateral involvement with enlarged kidneys. We have to see look for the sonography of the parents. So mostly if the parents is involved, it's autosomal dominant polycystic kidney disease, and if there are hepatic cysts, we think about autosomal recessive polycystic kidney disease. And in small or normal kidney size with medullary cyst, most likely the diagnosis could be nephronophthisis and medullary cystic kidney disease. small or normal size kidneys with cortical cyst. The differential diagnosis could be autosomal dominant polycystic kidney disease or glomerulocystic kidney disease. And there are various familial and hereditary cystic dysplasias in wide variety of syndromes like Meckel syndrome, Jones syndrome, Zellweger, and orofacial digital syndromes. Medullary sponge kidney present in adult age, characterized by dilatation and cyst formation in the medullary collecting ducts. Thank you.
Thank you, Dr. Maheshwari, for a very comprehensive review of multicystic dysplastic kidney. We'll start with, we have a few questions in the Q&A box. So the first question is for Dr. Vasudevan. Is HNF1 beta score a good tool to decide whether to do genetic testing?
So, so there are no definite predictors for HNF beta, but what the group from Belgium and France tried to do was to create some scoring criteria. And they did identify kidney hypodysplasia, presence of renal cyst as a common feature in those with an HNF1 beta, and in addition having hyperuricemia. So this could be used to do some kind of a prediction, but cannot be relied on to decide whether a genetic testing needs to be done or not.
Okay, thank you. The next question is also for Dr. Vasudevan. In clinical practice, should criteria be evolved for genetic testing? Should ACMG criteria be modified for CAKUT?
So there are a lot of limitations in the existing ACMG criteria while trying to predict the deleteriousness and causality, and that is in general, not specific to CAKUT. And more recently, they have modified that criteria so that they can even assess the variant classification for copy number variants. The key challenge in CAKUT is that most of them have an autosomal dominant pattern of inheritance. So that makes it a little more difficult when you identify a heterozygous variant in a child or an adult to attribute causality, because these could be quite frequent in a general healthy population, and especially in Indian and other population, the allele frequency is not well known. So it becomes a little difficult. But there is no, of course, these classifications are being modified, and there is a group called the sequence variant interpretation group of the ClinGen, which is part of the NIH, that are working on producing disease-specific criteria to identify pathogenic variants. And in that, there is a kidney group that is looking at glomerular disease and cystic kidney disease. And we hope to have some refinement in that classification.
And I think some of that kind of correlated with the findings of your own study, where you didn't find any known pathogenic variants in your group, in your cohort of patients with CAKUT, which just kind of highlights the challenges of linking gene mutations or abnormal variants to causality.
And also a practical thing which I want to highlight also from a clinical, because now the genetic testing is ordered by the clinician directly and they receive the report. No longer involves the genetist. So it becomes very important to counsel them of the probability of identifying a VUS, so that you can react to that once you receive the report.
Yeah, I think I would reiterate that at least for CAKUT, as our understanding of genetic abnormalities is evolving, working closely, and you highlighted that it should be a multidisciplinary approach with a geneticist or with an expert like yourself who has a good understanding of gene mutations and causality should be there. I don't think it's just it's not where a clinical, it can be left up to the clinician alone right now, the field of genetics and CAKUT. Thank you. The next question is for Dr. Maheshwari. How should one follow up or investigate an infant with the unilateral MCDK? How extensive the follow-up should be? And I think you did mention that, And I would add to this, like, how long do you follow up in your practice these patients? So, Dr. Maheshwari.
Normally, the protocol says that we usually follow up till the dysplastic kidney involute every 6 to 12 months, and later on we can do a regular follow up. Up till 5 years, we can do a yearly follow up with US ultrasound, BP blood pressure monitoring, urine analysis to look for proteinuria, and creatinine. And if the kidneys have involuted, mostly we expect the kidneys to involute by 5 to 7 years of age. Later on, at one sonography at around 10, one follow-up at around 10 years, another follow-up at around 15 years, for a pediatric nephrologist would suffice. And later on, they have to be cautious regarding taking any nephrotoxic medications, because they have a single functioning kidney, and they have to be following up with a adult physician because it's found that they could develop hypertension or proteinuria later in their adult life. So during the pediatric age group, till 5 years, maybe every 6 to 12 months, and later on at 10 and 15 years, if the kidneys have involuted and there are no complications.
Okay, thank you. I would like to add to what you had presented about OVIRA, obstructed hemivagina and ipsilateral renal agenesis. And I just wanted to share our experience with the audience that, in female patients with MCDK, be careful about OVIRA right around the time of puberty, because that's when the obstructed hemivagina will present with onset of periods with abdominal pain. Because we were able to we saw a couple of these patients right around puberty when they presented with abdominal pain, and their ultrasounds revealed obstructed hemivagina, and then they needed surgical intervention. So now we have changed our practice to counsel, and Dr. Maheshwari did mention that. So, just a clinical anecdote that just remember to watch out for that right around puberty. Our next question is for Dr. Vasudevan. Which group of non-syndromic CAKUT needs genetic study?
So if there is a familial history, if there is more of a renal parenchymal abnormality, severe hypodysplasia, and with presence of extra red kidney features such as renal coloboma, where you have a coloboma or a sinus such as in brachioautorenal syndrome, they are more likely to have an underlying genetic etiology. See, these are the patients who will benefit with genetic testing. There is no indication as such because of the challenges that have brought about in general if you have an isolated CAKUT. So I would, in my clinical practice, I'd go for a genetic testing, not in all children, but very specific subgroup of especially syndromic, and if they have identified a strong family history.
And another thing, which all of means pediatric nephrology is a very, very niche community. I always feel we can always reach out. So I can tell you, if next time I have a question, I'm going to reach out to Dr. Vasudevan by email and ask him, would he do genetic testing or not? So that's another way to decide whether to do genetic testing or not, because, sometimes it's just not clear. The next question is for Dr. Maheshwari. Why should MCDK patients be hypertensive?
It is mostly because of the disorganized parenchyma, which results in activation of renin-angiotensin Aras system, which results in hypertension.
Okay. When you kind of attribute hypertension to the MCDK kidney itself and then consider nephrectomy because of that, right?
Yes,
That's the
well, if it is not controlled with any ACE inhibitors, then we may have to do a nephrectomy in case of refractory hypertension.
Do we need a DMSA scan or any kind of functional scan for unilateral MCDK if the other kidney is hypertrophic and there are no concerns on urine analysis or serum creatinine?
Definitely. DMSA is a confirmation for a unilateral multicystic dysplastic kidney, and also to note the function of the contralateral kidney. Definitely, DMSA has to be done.
Thank you, Dr. Maheshwari. I'll actually, I'll share our practice because, when I started our fellowship, we used to routinely do functional scans. And over the years, we have taken, like one of our attendees pointed out, the increase in size, the hypertrophy, appropriate hypertrophy of the contralateral kidney, and a normal urine analysis and a normal chem panel as a surrogate for a functioning kidney, and have moved away from DMSA scans. And, part of the USA practice is also governed by, which tests are covered and which are not covered by the insurance agents, so agencies. And that's what we do currently. So that could be an acceptable alternative approach.
Okay, sir. Okay. Thank you.
When should surgical treatment be considered if cyst is not involuting in patients with MCDK?
I think the cyst is not involuting, especially if it is more than 7 centimeter. We don't expect it to involute. We wait, I think we wait till 5 to 7 years of age. And then we have to decide upon nephrectomy. And because most of the cysts, they involute by 5 to 7 years of age. Cystic dysplastic kidney, most kidneys involute by 5 to 7 years. And more than if it is more than 7 centimeter, maybe the nephrectomy can be considered early in life also.
So I think that kind of ties in, Dr. Maheshwari, into the next question, indications for nephrectomy, or I could rephrase it that, like, if MCDK is not involuting, then would you consider routine nephrectomy at the age of 7 years, 8 years for your patients?
Depending upon the size.
Okay. So more than 7 centimeters is when you would consider nephrectomy?
Actually, to be frank with you, we have no separate guideline to say when to do nephrectomy.
Okay.
Generally, using clinical experience and your knowledge, when you find the cystic kidney growing in size, then we are a little careful. And when we suspect some evidence of malignancy, which is very, very, very low, then we do. And then if you are associated with hypertension or proteinuria, this thing. But the problem is the so-called normal kidney also may be mildly dysplastic, because CAKUT is not a single kidney apparently. So that's where the small fear is text. Should you remove? So generally what we do is, we try to avoid doing nephrectomy. Some years back, we were doing nephrectomy actively. The surgeon will be called, he will do the kidney and then show it to us, see how good it is. But then we learned it's not necessary. So we try to keep as much as possible avoid. Use nephrectomy only as a last emergent case of hypertension or growing in size, or to suspect something going wrong, then we do it. There's no there's not fixed guidelines, I think. And it will vary depending upon the individual's own experience about it. But some 20, 30 years back, we saw, we used to, moment we saw this dysplastic kidney, we used to call the urologist, and he was very happy to remove the kidney. Now we know it's a sin to remove a kidney. Whether it's sick or not is sin.
Or when we have recurrent,
No?
when we have recurrent urinary tract infection, which is attributable to MCDK kidney, or hypertension, which is attributable to MCDK kidney, then we tend to do a nephrectomy. Otherwise, routinely in India, we don't do so.
No, anywhere. India, the world.
Yeah.
No, I think that's what it is. As Dr. Namalwar pointed out, the practice was different 25 years ago or so, when routine nephrectomy was recommended. And as Dr. Namalwar mentioned, that, either the peds surgeon or urologist would be called, and the nephrectomies would be done. And I think that was the practice in US also. But now that has completely changed, and there is no routine indication. And then as all of us are mentioning, there are certain indications that you would go ahead with a nephrectomy. Sometimes I notice that, the involution has started, but then sometimes you see an increase in size after a couple of years, and those would need a reinvestigation, and you have to reconsider the diagnosis. And those kids may need a nephrectomy. And then Dr. Kalavani, as you mentioned, I think recurrent UTIs, hypertension coming from the MCDK kidney, those would be some of the indications.
I have a question to Dr. Kalaivani. What is the cause of recurrent UTI in MCDK, multicystic dysplastic kidney? Is it in the normal kidney or in the abnormal kidney?
Like if the child is having an atretic ureter or reflex in a MCDK kidney, that can contribute to UTI, sir. Otherwise, usually the MCDK kidney takes the brunt of it. It usually prevents a normal kidney from getting UTI. If the ureter is atretic, then or if it is a reflexing along with the MCDK kidney, then the chances of UTI is high, sir.
But if it's atretic,
then the other kidney, we should be little careful. Then the DMSA scan, ultrasound, if it shows any ureteric dilatation, then we do MCU and we can relate the UTI to the reflexing ureters in the normal kidney.
good.
I'm not sure, sir, but like I think
Okay.
Dr. Gauram and Namalva sir can add up to it.
No.
And Amrish can add up to it.
That remains an unanswered question to me. That is why I asked you.
Yeah. No, I think classically you should not see UTIs in the MCDK kidney. That shouldn't really appear. And that's why we always question that, are we actually dealing with the MCDK kidney? Because, the approach Dr. Gaurav mentioned that, we don't do routine DMSAs for these patients. So we never classically diagnose them with MCDK. It's a clinical diagnosis based on radiological finding. We actually don't even do routine for like a VCUG for these patients also. If the kidney looks normal, hypertrophied, no hydronephrosis, the contralateral kidney, then we don't even do VCUGs. Only if they have UTIs, then we would do a VCUG for these patients, which is, again, a practice that has evolved. When I started training, that time we were doing routine VCUGs, routine DMSAs for all these patients, but now we monitor them clinically. So there is always a chance that they may not be classical MCDK. And that's why if these patients are getting recurrent UTIs and you have not evaluated or confirmed the diagnosis with the help of a DMSA, at that point in time, they would need a detailed evaluation in the form of VCUG, maybe like a MAC3 scan, see what their function is like, and then the decision to do nephrectomy can be made. So I think that's why the practices have, because our investigation practices has changed. I believe, I think our indications have also evolved, because sometimes we may not be dealing with these classical MCDK.
Yeah. No, and that's exactly what we do. Means, we just, and one of the participants has asked a question: do you need an MCU or a VCUG to rule out VUR in MCDK? And we don't. Means unless you see a UTI, you cannot ignore a UTI in especially recurrent UTIs also in MCDKs, because the whole aim of MCDK kind of in our practice is to save the good functioning kidney. And Dr. Maheshwari also mentioned about the use of, avoiding the use of nephrotoxic medications and follow up to make sure hypertrophy is there. There is another question that comes up here. Post-involution, they are at risk for hypertension. Should we follow up more frequent after 5 years rather than at 10 years for hypertension? This is for Dr. Maheshwari.
If they have found hypertension, so we need to follow up more frequently than, following up to 5 years or 10 years, definitely for the indication of hypertension. Only if there are no other issues, we can follow up less frequently.
Yeah. And in our practice also, we kind of monitor them for, like I said, for the normal kidney. And, as they are getting older, if there is chances of them being a little bit obese, which we do encounter in our practice quite a bit here in US, we do monitor their blood pressures and counsel them accordingly. I have, another thing that comes up very frequently is sports participation in patients with the MCDK. And I know the sports are different in different areas, But any comment on that, Dr. Maheshwari, about contact sports and risk of injury to the normal healthy kidney?
Apart from, I don't think that apart from any normal sports are allowed for any children with a normal functioning kidney. So if there is a large abdominal mass, then we would advise to avoid contact sports.
Yeah. Yeah. And, I think the practice is, it kind of evolves across regions, because in US, we have two very intense physical sports, which are at high risk of blunt injury to the belly. But again, still the recommendations are to not restrict any sports participation, like you said, but we counsel them about the risk of potential injury to the single functioning kidney and then leave it up to the parents. We are reaching 10:23, and I know we have a polling to go, but there are just a couple of things, but we address those, like lifespan of unilateral MCDK. It just depends on the involution, as we had in the panel discussion. And you kind of decide about the follow-up based off on that. It may just persist. And like Dr. Namrawal sir pointed out, we've moved away from just removing them if they persist and kind of rely on clinical indication. We talked about the interval follow-up for cyst involution in MCDK. And then one last quick question for Dr. Maheshwari, and we'll close up. For bilateral polycystic kidney, infantile onset, what is the prognosis?
So bilateral polycystic kidney disease.
Yeah, I think it's a little bit different than MCDK, but the viewer, that Andy pointed out, so I'll just let you have it.
So in infantile onset bilateral polycystic kidney disease, if it is autosomal recessive, the prognosis is little worse than the late onset, because the child will be hypertensive, and the child will need a very close follow-up. The child will have liver involvement, and unless and until liver and renal transplant is done, the survival of the child will be is very difficult. Because I assume that infantile onset polycystic kidney is mostly autosomal recessive, because we don't see autosomal dominant polycystic kidneys so young in young age.
Yeah, I think that should address that viewer's question. It really depends on the serum creatinine there, and then how the disease process is going to evolve. With that, I'll close the Q&A session and hand it back to the organizers.
I just have one comment on this bilateral cystic. I was not sure whether the attendee was intending whether it's a bilateral multicystic dysplastic. We sometimes do get these kind of reports post-birth in infancy, and we joke saying that if you get a report like this, change the radiologist, because that's not compatible.
I think you're right, Dr. Vasudevan, that got to change the radiologist on those ones. So thank you for a very stimulating discussion to all. Thank you for your questions. I will hand the session back to the organizers, Dr. Ganeshan and Dr. Jain.
I just have a small comment. So we did have a bilateral multicystic dysplastic kidney, but the creat started dropping. I was actually surprised, but then we did a DMSA after 3 months, and to our surprise, the baby had an ectopic kidney, which was actually functioning. And it was not picked up by ultrasound. So thank you so much, Anil sir. Thank you so much, Uma Maheshwari.
Thank you.
Thank you, Dr. Gaurav, for that excellent moderation, and thanks for accepting our invite as well. Can we go move on to the polling session now, sir?
Yes, let's do that.
So we'll have the instruction for the polling session. So totally we have 10 polling sessions. We are already done with one polling session. And today the duration of timing is going to be just 6 minutes because we don't want any participants to go Google search and sort out the answers for it. And out of 10 questions, we'll have 3 star questions, and that star questions are taken into consideration only in case of tie. And only trainees are allowed to participate in the polling session. I think we'll go up with the polling session now. The polling questions are visible now, and we'll have next 6 minutes for the polling sessions to get closed. We have 1 more minute for the polling session to close. Fifteen seconds more. We can close the polling session. Dr. Amrish can do the closing remarks.
Yeah, this was an excellent session. Thank you so much, Dr. Vasudevan, for such a comprehensive talk. And I really like the approach, like which kits to be tested, what tests should be ordered, how to interpret the test. I think that was a great learning experience. So thank you so much for sharing with all your years of experience with us. So thank you so much. And then I want to thank Dr. Uma Maheshwari for her excellent talk. We saw how much discussion it generated, because we know that there is differences in practice in multicystic dysplastic kidney. This has really evolved over a period of years. It was wonderful to have Dr. Namalwar's experience, to have the discussion behind us. It has been, again, a great learning experience. And thank you so much, Dr. Uma Maheshwari, for giving such an excellent talk. We really appreciate that. And in the end, I want to thank my wonderful mentor and colleague, Dr. Gaurav Kapoor. He moderated the session very, very well, and it was great discussion. And thank you again, all of you, for joining. And we will look forward to the next webinar on Wednesday. Thank you all for your time.
Thank you, Dr. Thank you, Dr. Gaurav.
Thank you so
Thank you.
much. Sir.
Thank you for having me.
Thank you, Dr. Gaurav, for the excellent moderation. Thank you. Thank you, Namalwar, sir. Thank you, Umar. Thank you, Dr. Amrish. Thank you.
Thank you all.
Bye-bye.
Thank you.
Happy weekend.
Thank you.
Yeah.
Bye-bye.